Hello and good morning. My name is Josh Sharfstein from the Johns Hopkins Bloomberg School of Public Health, and welcome to this session of the Population Health Roundtable of the National Academies of Science, Medicine, and Engineering. We are starting a series this week on population health in challenging times, insights from key domains. And there will be conversations happening throughout the week in 5 domains: academia, philanthropy, public health departments, healthcare, the social services sector, and then some cross-sectoral conversations. Each of these conversations will be anchored in the incredible moment of time that we're finding ourselves in. A global pandemic with nearly 1 million people who have died across the world and almost 200,000 here in the United States. A pandemic that has also revealed profound and exposed profound inequities in our society and societies all around the world. Most recently with the startling statistic that more than 75% of children who have died are in racial and ethnic minorities from coronavirus. Related to the pandemic is this crisis that reflects the exposure of racism in our society, the murder of George Floyd, the protests that have followed, and the recognition that it's not just law enforcement that has a reckoning with race, but many other fields, including health and population health as well. There are other crises that are affecting our health. The overdose crisis has not gone away. In fact, it's gotten worse in the last year, and it's likely getting worse as a result of the pandemic. We have a crisis in our food system leading to epidemic levels of hunger in the United States, with many families unable to provide food for their children. And these are just some of the factors that make this an extraordinary time for the country and an extraordinary time for our field. And so the discussions that will happen this week are going to be about what each of these domains can do to rise to the moment, to respond to these crises, and to provide a greater vision and support for the country and the world moving forward. So I want to turn to the fantastic group of people who will be participating in this discussion. And before I do so, I'll explain how we're going to structure it. So we have an all-star team of people from academia, and we're going to be focused on what academia can do at this moment of crisis in public health and population health. We're going to have each of the individuals talk about one particular idea for a few minutes, take a couple questions from the group, and we're going to rotate and cover quite a lot of ground pretty quickly. We'll then have time for a more general conversation, and we'll open up to questions from all of you who have joined us. So thank you very much for coming, and we're going to now go around just so you know who is participating. And I'll start with Dr. Dora Hughes.
Good morning, and thank you, Josh. My name is Dora Hughes. I am an associate research professor within the Department of Health Policy and Management in the Milken Institute School of Public Health at the George Washington University in Washington, D.C. Thank you.
Great. Ziad Obermeyer.
Hi, I'm Ziad Obermeyer. I am an associate professor at the Berkeley School of Public Health, and I do research on machine learning applied to clinical and policy decision-making.
Great. Professor Sheri Johnson.
Hi, I'm Sheri Johnson. I'm the director of the Population Health Institute at the University of Wisconsin School of Medicine and Public Health.
Great. Dean Sandro Galea.
Hi, everybody. Good morning, good afternoon. I'm Sandro Galea. I'm the Dean and Robert A. Knox Professor at the School of Public Health at Boston University. Thank you for having me, Josh.
Great. Dr. Marc Gourevitch.
Hi, I'm Marc Gourevitch. I chair the Department of Population Health at NYU Langone Health, and I'm a professor there in the department and in medicine as well.
Great. And Dr. Shreya Kangovi.
Good morning, I'm Shreya Kangovi, and I'm an associate professor at the University of Pennsylvania, Perelman School of Medicine, and then the founding executive director of the Penn Center for Community Health Workers. I'm delighted to be here. Thanks. Great.
So you can see we have quite a range across public health and population health, from the data sciences to community based work, and it's going to be really an interesting conversation. As I said before, we'll go one at a time with a few minutes to present an idea, a little bit of discussion, and that'll allow us to put a whole bunch of interesting ideas on the table for when we all jump in. I'm delighted to start with Dr. Dora Hughes. Dora.
Thank you. And thank you again to the Roundtable for inviting me to participate in this panel today. I was struck by the very long list of challenges that we're facing that Dr. Sharfstein outlined. Of course, I would add climate change, certainly with all the attention to the fires as well as the floods, and the resulting displacement and exacerbation of the homelessness crisis to the list. But even before we dive in, I did just want to acknowledge, even though not at all related to my remarks and possibly not to the panel, but I did want to acknowledge the death of Supreme Court Justice Ruth Bader Ginsburg on Friday. Just truly a champion for democracy, Supreme Court icon. And also that we are having this discussion, certainly within the context of the upcoming elections, and many of the issues that we're talking about right now are very much part of the national dialogue, and we hope will weigh in on the decisions of Americans as they go to the polls. And so I think this is a very historic time for so many of the reasons as outlined by Dr. Sharfstein, as well as some of these other issues that are swirling around before us. As I was thinking more specifically about the charge to this panel, I was reminded of a quote by author James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it is faced. And across all of these crises that we've discussed is a common theme, that being an unwillingness by too many and for too long to acknowledge and meaningfully address many of these incredibly complex and devastating public health issues. And one of the reasons why is that we often don't have the evidence or access to the evidence, the data, if you will, that we need in order to recognize the issues and develop effective strategies. Therefore, although there are so many critical roles for academia, the one that immediately jumps out for me is the need for academia to take a stand for and be an advocate for science and for transparency. If we focus on the pandemic, it is notable that the CDC did not report even the demographic data that it had for many months, which would have highlighted earlier the disproportionate impact of the pandemic on Blacks, Latinx, Native Americans, low-income groups. Certainly none of us who work in public health were surprised at the inequities, but still the scale and the magnitude were startling, and in a very dispiriting kind of way underscored how much work needs to be done to prevent avoidable, unfair, and remediable differences in health. Even more concerning have been the recent reports just this past week of political appointees within the administration trying to clamp down on CDC's release of morbidity, mortality weekly reports that contained information about the pandemic, with one high-level former official accusing the CDC scientists of sedition, no less. And it's not just the CDC. I would also note your role, Josh, along with Dr. Peggy Hamburg, in highlighting the dangerous and erroneous conclusion by FDA that plasma was a proven treatment for COVID-19. The title of the op-ed that you released in the Washington Post was that the FDA must stand up for itself and for science, not politics. So, back to academia, certainly because of the federal void of data, in the earliest days and even now, we have relied on scientific data analyses from many universities to understand the scourge of COVID-19 and all of these other issues that we discussed. But I would even have to say relying on academic partners is not unique to the pandemic. I would note GW's role in determining the true number of casualties, or excess deaths, if you will, from Hurricane Maria in 2017. I mean, at the time, there was an official account of 64 deaths from the storm. For 11 months, 64 deaths was the official number. And that figure stood until the GW report came out with an estimated nearly 3,000 deaths. And even then, just as now, there was pushback from the administration. There were some tweets casting doubt and claiming political motivations for the dramatic increase in number, even as the governor of Puerto Rico accepted the report and committed to improvements in preparedness and response. So the question is, how can academia strengthen this role, i.e. promoting and safeguarding and advocating for science and transparency? First, at a high level, I think that universities should redouble their commitment to this role more publicly and more explicitly as part of their dedication to teaching, research, and service. Second, especially in times of crises, but also for dealing with society's most intractable issues, I would like to see a more structured and organized effort, both to identify the issues and data that's needed, as well as who is doing what, who has the experience or could be tapped to participate. This could happen under the auspices of certain public health focused associations or membership groups, through standing committees or through working groups that could be formed and only activated when needed. Even if not quite that formalized, I think that academia should collaborate or at least coordinate more to make sure the main questions and concerns are being covered and to explain their various approaches and methodologies. I was struck by the difficulties by some public health leaders in trying to figure out and explain publicly which modeling they had adopted for their pandemic planning and why. I think more conversation is needed to help out public health leadership during these times. I also think these efforts should be cross-cutting across institutions, which would bring greater resources to bear, but also a diversity of perspectives. This already happens in some cases, certainly, but I think there could be a role for philanthropy and other entities to support such a high-level effort. Fundamentally, I believe academia is a truth teller. We should be clear that in addition to protecting science and transparency, which is important in and of itself, truth-telling is also important to support and in many cases provide cover for public health professionals on the front lines, who we know are being harassed and intimidated for fulfilling the duties of their role. A report in August found that at least 49 state and local public health leaders have resigned, retired, or been fired since April across 23 states. Some of these numbers reflect burnout and other issues, sure, but many of these individuals also experience professional and personal attacks and unremitting hostility over conflicts over mask orders or shutdowns to enforce social distancing. At its core, science and transparency promote trust and accountability to those that we have pledged to care for, and they must remain a fundamental and highly visible component of our essential mission and work. So thank you. I'll conclude there, and I look forward to any questions.
Thank you so much, Dr. Hughes. That was terrific and a great start to this conversation. I want to jump in with a quick question for you. At one point, one of our graduates at Johns Hopkins was fired as the health commissioner. We actually released a statement from the school defending her, which became a political issue in the state. The governor was asked about it. It was sort of along the lines of where you ended there, that academia has to stand up, particularly for truth and support, in some cases, public health officials in the midst of these political battles. What do you think are the answers to people who work in academia but are reluctant to engage in that kind of political space? Can you do what you're asking outside the political space? Is it inevitable that you're going in? What happens when accusations, or at least the rough and tumble of politics hits, which usually academia stays out of?
I think that's an excellent point. I mean, to be fair, I would note that the individual that you mentioned was not working in academia when she received the pushback and was fired and had to face her own reckoning over what was the right pathway forward. And I also note that another individual who engaged in some of the pushback against CDC and the MMWR that came forward, a university which he was affiliated, I believe, in Canada, pushed back and said that his actions were not within the context of academia, but in his role at HHS. And so I do think, I say that and I think within the walls of academia, we have considerable flexibility and the latitude to speak the truth and to adhere closely to the evidence and to the data and the science. I do think that where some of the pushback comes is when you're outside of academia and you're in the roles of implementing some of the programs and policies that are politically driven and motivated in many cases. And that's where some of the issues, or if you're serving at the pleasure of the state and local government, that's certainly where you're seeing some of the pushback. But I think even though I will be the first to admit it's not a bright line, that within academia, we don't have some of those same pressures. And so therefore we should be willing to lean forward and push on to make sure that we are highlighting and promoting science and transparency.
Great, fantastic. Any time for one other question from one of the other people here in discussion, or we can move on? All right, why don't we move on? But Dr. Hughes, thank you very much for mentioning Ruth Bader Ginsburg's career and what she meant to so many people in this country and around the world. I also want to let people know who are watching that if you are inspired, as I am, to tweet by anything that you hear, then you should use the hashtag PopHealthRT, PopHealth with the capital T for the Population Health Roundtable that's sponsoring today's discussion. I next want to go to Dr. Marc Gourevitch. I think, as Dora alluded, the academia has played a very important role in these different crises over time. And I think we're interested in hearing your views on, how to consolidate and accelerate in importance the work that academia does in these critical moments.
Terrific. Well, thanks for this opportunity and to really come together and think about these very hard issues. I'll tell you, I'm struck by thinking about how can we up our game in terms of the impact of what we know, in terms of the impact of some of the basic true things that academia has already contributed to. So if you take a step back, academia's role has been to advance new knowledge. The time-tested idea is really that academia figures out new things about the world, and then society becomes better because of how this knowledge and innovation diffuses into the mainstream. New medicines, new technologies, new economic frameworks, new immunizations. But let's be real. What to a great extent, we know a great deal about what to do to stem some of the crises that are intersecting right now. With COVID, we knew right away about masks and social distancing. With opioids, we understand effective prescribing practices, effective medications that are still stigmatized. On the economic side, the impact of a living wage, and so on. It goes down the line. We don't need necessarily more research to understand that chronic disinvestment in Black and Brown communities has had the toll that we're seeing today. So we are besieged by these multiple crises. We've thought in academia long and hard about them. There are many examples of sound learnings and programs and policies and platforms that have been put forth. But where are they all when we need them? They're out there to some extent, but to too great of an extent, they're on the shelf. They're not in widespread uptake, and they're not embraced as basic things that work. And when we ask, and the reasons for that, as everyone listening here understands, are complex. But rather than think about sort of, well, what are the additional unknowns that we might shed sharper light on, which is important in academia as we go forward, I think there is really two, there's really a largely untapped area, which is to devote much greater focus on influencing narrative, including political narrative, to more effectively frame public attitudes towards basic things that work. Masks, approaches to community level investment, let's say, climate change, you name it. So many are, or I shouldn't say many, some are working on this. Sarah Gaulis, Jeff Nieder-Jeppe, Steve Wolf, others. But they're still on the periphery. Their work is fundamental, but it's not widely understood and known. If you think about the shift in our field over the last 10 years in, let's say, implementation and dissemination research, nobody was, not nobody, but it was largely obscure 12, 15 years ago, and now it's widely thought about. What about what about seeing and advocating for a parallel rise in the science of framing basic approaches that work? It's not simply about implementation. It's about truth-telling, and it's about narrative shifting, sort of communicating science in ways that align more broadly with people's values. It's really a blend of psychology, behavioral economics, communications, sociology, and it also entails a shift by our institutions to lift up that kind of work to the highest level and really to sort of value it with the great science that we will surely continue to see. So that's really my pitch for academia, is to focus squarely on the and with force on asking how information about what produces health can be conveyed to more effectively shape public attitudes and health-related policymaking.
Great. I want to see if there is anyone in the group here who has a question for you, Dr. Gourevitch. Thank you so much. So we're adding to promote science and transparency, stand for science and transparency from Dr. Hughes, to really influence the public narrative on what works as a major role for academia. I guess one question, Dora, do you have a question?
I was just curious if Marc had examples of what has worked in certain instances that could be models for us moving forward.
I'll tell you, the one that jumps to mind, I'm not sure it's the best, is the framing of the obesity epidemic maybe 5 or 8 years ago as an issue that affected also military preparedness. So there was some of you will remember the details of this better than I, but there was a point where a report came out that looked, and essentially it was difficult for the Army, I believe, to recruit enough recruits because people weren't passing the exam, the health exams. And that got a lot of attention. And instead of it being about, nanny state and overregulation, it was about, wait a minute, we need to focus in here. So that's an example of a narrative shift about it's the same issue, it's the same people. And that I think was quite powerful at the time. and is an example of ways to appeal to a broader set of values in framing some of the important messages. Yeah.
And Marc, is this a research agenda and an action agenda? Like how to do this well, and then you have to go out and do it? Or is it more one or the other?
No, I think it's both. I think we probably don't understand I would say we probably don't understand enough about this and at the same time, there are some who do, who I think we can begin to learn from at a more rapid clip. So I would have it bridging both spheres, but it's also a matter of working it into the marrow of all, not this part of this department at this institution, but really of having it infuse all of our work and language and efforts.
Great. Thank you. Okay, why don't we move on to Dr. Sheri Johnson, the director of the University of Wisconsin Population Health Institute. I will turn over to you.
Thank you, Dr. Sharfstein. So in preparing for the time together, I was thinking about the ways that those of us who work in academia, particularly in public health and population health, can better address the conflation of race and racism, both in our teaching and in our scholarship. And so I've thought about this a lot as really as a practitioner and as a person who works at an institute where our tagline is translating research for policy and practice, but also as a teacher. University of Wisconsin is an integrated school of medicine and public health. So we have the privilege of teaching the future medical workforce as well as the future public health and population health workforce. And so I think one of the things that we need to do in academia right away is to really interrogate our curriculum and look at the presence and balance of content that we include in our curriculum that defines race as a social construct. So this idea of race has sort of dogged us for a long time here in the United States and certainly around the world. It's an idea that has been central to the way that we have evolved as a nation. And even one of the original founding fathers thought about this issue, Thomas Jefferson. He wrote in Notes on Virginia that, quote, "I advance it therefore as a suspicion only that the Blacks, whether originally a distinct race or made distinct by time and circumstance, are inferior to the whites in endowments both of body and mind." So this idea that race is biological, and in particular that certain groups of people categorized into different groups are either superior or inferior, has been a question that we've wrestled with for centuries. And I think, unfortunately, in academia, we still have an imbalance of how we understand race as a social construct, how we teach about it, how we craft the questions that we ask in our scholarship. And so my one idea for us as academia is to really interrogate that in a comprehensive way, not in a sort of an extracurricular way. And students are really leading the way. So there's certainly evidence that this idea that race is biological is still very much a part of our collective thinking, both in academia and amongst lay people. For example, a study by Hoffman et al. Demonstrated that a sizable number of white lay people and medical students and residents have inaccurate beliefs about the biological differences between Blacks and whites, and that these beliefs predict racial bias in treatment recommendations. So it's not just that the ideas exist, but it's that the idea about biological differences between groups of people translate into the decisions that we make as public health and healthcare practitioners. We don't talk enough in academia, and I think this is beginning to change as we've seen the most recent reckoning with racism in the broader society, but we really don't integrate it in a systematic way. We don't really interrogate the curriculum in a systematic way to make sure that this conflation of race and racism is rooted out. I think that's really the way to long-term change, by making sure that the current and next generation of population and public health thinkers and practitioners have the proper frameworks to understand these constructs so that they can ask different kinds of questions and arrive potentially at different kinds of answers. So understanding racism then, as David Williams and others have defined, as an organized social system in which the dominant racial group, which can vary depending on what society you live in, is based on an ideology of inferiority that categorizes and ranks people into social groups, and that racism as a system uses its power to devalue, disempower, and differentially allocate valued societal resources. So if we were to really sort of inculcate our curriculum and our scholarship with those ideas, I mean, those are ideas that critical race theory utilizes. And certainly as we were preparing for this, I didn't anticipate that there would be an executive order that has really called into question the integration of critical race theory in academia, but it made this actually even a more timely set of reflections, because critical race theory, it's a framework that's been around since the 80s. To examine society and culture and the intersection of race in the ways that it's pervasive across all aspects of society, including housing, employment, education, public health, and the law. And it explicitly probes racism's influence on both outcomes and processes. It's an iterative methodology to help investigators remain attentive to equity while carrying out our research, scholarship, and practice. And public health critical race praxis also provides a framework for students of public health and medicine that is really instructive and can help us as scholars and practitioners ask important questions, such as how is racialization operating and contributing to whatever problems we're seeing? So how does racialization, for example, contribute to the disproportionate burden of COVID-19 in communities of color? Racialization describes how socially constructed racial and ethnic categories are used to order groups in society, and that ordering might relate to the ways in which African American and Latinx folks are essential workers and more likely to take public transportation to the jobs that they perform. So it's a way to really understand a layered things in a more layered way. And it does not really seek, in my view, to cast some groups as evil and others as not evil, but to really be truth tellers around the historical context that has shaped opportunities for some, that has unfairly advantaged some groups of people over others, and that those are the real drivers of differences in health and health outcomes that we see. So, as I said, students are leading the way, and I can say that the Alpert School of Medicine at Brown University, my undergraduate alma mater, the students there, Syed really looked at their own medical education and understood the importance of contextualizing and complicating the concept of race instead of simplifying it, as they say. So they examined their own preclinical medical education and found that out of the essential lectures, 102 slides mentioned race, but the majority of those suggested that race was useful for understanding biological risk. 38% of slides noted explicit biological differences. 58% implied a biological difference. Only 4% acknowledged social determinants of racialized disease disparities. So we have a long way to go, and we see this across lots of coursework in medicine and public health. I mean, it relates to the narrative that I think Marc was discussing. The narrative that we create really builds off of the way that we conflate race and racism.
Great. So
we have a narrative around inferiority versus a narrative around structural drivers and obstacles to health. The conversations that we then have and the conclusions that we draw are different. So I'll just say that I think rather than continue what I think has started since the racial reckonings that we've seen over the summer, rather than continue the thinking as sort of outside of the mainstream of our curriculum, it's really overdue time to integrate these concepts squarely in our teaching and scholarship.
Great, thank you. Thank you very much. Questions for Sheri? This is sort of academia, heal thyself a little bit.
I would have one question. Sheri, thank you so much for your comments. They certainly, your words made my heart sing. For those schools that are going to tackle this and they do want to integrate their curriculum and all the steps that you mentioned, do you think that we have sufficient tools and resources available? How far advanced are we in terms of thinking how we could and should integrate this into our teaching?
Yeah, I don't think we're very far along. I mean, I think that this study that Ziad did was in 2014, and it was really one of the first that looked at a medical curriculum with that lens of differentiating between race as a social and a biological construct and differentiating between race and racism. And so I think we're early in the effort, and I think that sometimes we get, it's easier to do some of the easier things like teach about cultural humility or implicit bias, which I do and which I think is important, but that more comprehensive curricular overhaul and comprehensive interrogation of our curriculum and scholarship, I think we're still very early on.
Great. Well, thank you so much. This is, we're really we were putting some great and important issues on the table. Let me jump in. I'm going to be very brief within the perspective that I was going to bring, which I think is a good addendum or at least connected to what Dr. Johnson has been talking about, thinking about how education, public health and population health education needs to change. I think of this in two ways. There's the process and the substance. And the process, I saw a great article by Dr. Galea, who'll be speaking in a minute, talking about the importance of getting the technology right so that people can really connect, recognizing the trauma that people experience and making sure that the curriculum and class experiences are trauma informed, and also thinking of teaching as a shared enterprise. This is from his article about not maybe just one person at the front of the class, but much more of an engaged process, really drawing on expertise and information from a lot of different corners, which all makes sense to me. I think substantively, we have to think about this moment of crisis as a kick for academia to be teaching more about how to respond to a moment of crisis, how to recognize when there's a crisis that may command attention, how to be relevant to the national and local conversations that are happening in a crisis, and how to respond effectively with projects that are not just directly at the narrow public health project that maybe is the most obvious for a public health official to work on, but also to be able to see a little bit more of the field and to be more of a strategist for how some of these broader issues can be controlled. I think there's, for example, an applied health equity a need for understanding in our students and practitioners. It's one thing to really recognize and do the great epidemiology report showing the tremendous impact of this pandemic on particularly African American and Latino communities, but then to be able to say, let's do A, B, and C, crossing in some cases to other sectors, addressing these questions of the transportation sector or low-wage jobs. What is the role of public health in those areas? Those are things to both, I think, to not only frame up in the academic environment, but to be able to teach with students. And ultimately, I think a lot of public health officials, as Dr. Hughes mentioned, are getting hit by the bus of politics at this moment. And I think it's time for more explicit teaching about what the political environment means and how to be prepared for it and protect yourself for it. So those are some thoughts about how we have to think about public health as a field that is activated in crisis and can really become relevant. I will, though, defer questions on me to keep us moving here and maybe move on to our next speaker, who I believe will be Ziad Obermeyer from the University of California, Berkeley.
Thanks so much, Josh, and thanks for having me. I thought I'd talk also very briefly about little things that matter a great deal. So I think in academia, we are kind of stuck studying little things because we have to write papers that are like these beautifully crafted little jewels that, talk about one particular thing in one particular place. The reason I like little things is because sometimes people just don't pay attention to them, even when they're very important. So if you're as tired of watching Zoom conferences as I am, I'll just tell you what it is. We often use healthcare costs to measure healthcare needs. And that seems like a very small technical thing that brings up a lot of, boring issues around measurement. But there are two things that I've done research on over the past year or so that's convinced me that this is actually a really important thing to study. A year ago, with some colleagues, we studied an algorithm that was used in many, many different health systems across the US, and is also a type of algorithm that's used for millions and millions of people's decision-making around the world to help allocate population health interventions, like who gets extra help with a nurse practitioner to manage their medications, to come do a home visit. The way those algorithms work is they predict how much that person is going to cost next year, and they allocate extra help to people who are predicted to cost a lot. And what I didn't realize, and many people didn't realize until we studied this issue, was that built in large-scale racial disparities, because healthcare costs are not the same as healthcare needs. When people who need healthcare don't get healthcare, they cost less than people who have access to healthcare. And that builds in disparities against non-white populations, poor populations, rural populations, and anyone who either doesn't have access to the healthcare system or is treated differently when they get access to the healthcare system. By working with the company that made that algorithm and with a bunch of health systems and software developers now, we're working to fix that bias simply by flipping a switch in the algorithm, by predicting different measures of health that don't have to do with healthcare costs. We're trying to turn an algorithm from one that was fundamentally regressive and entrenched all of these social and socioeconomic disparities to one that gets extra help to people who actually need it. And what I like about that is that unlike trying to fight human biases, which is very, very difficult and requires persuasion and incentives, and for all the reasons that Marc mentioned earlier is very difficult, fixing algorithms is much, much easier. And overnight, you can flip a switch and turn that algorithm from a force for injustice into a force for good. Now, one way to think about policies is algorithms for government and large systems. And the same bias exists in the way our federal government was allocating money for COVID relief to providers. So just like the algorithm, the way the CARES Act allocates funding was by looking at how much revenue a hospital brought in last year and giving it money proportional to its revenue. Like the algorithm, this was not an unreasonable choice, and it reflects the fact that we don't have great measures of who needs help. But just like the algorithm, that policy built in the exact same racial biases, as we showed in a paper that we published a few weeks ago in JAMA. Just like the algorithm, there aren't a lot of entrenched incentives and persuasion that you need to do to fix that, that wasn't even entrenched in the CARES Act itself. The CARES Act just said, get money to where it's needed. And someone decided how to measure that need. And so just like someone decided to measure it with revenues, we can turn that measure into more sensitive revenues that measures that reflect who needs help rather than who simply has brought in money in the past. So I like these little things because, unlike the big things, they're ways that we as academics can really contribute to understanding an issue and then to turning that understanding into real change in the world.
Great, thank you so much. Just to see whether there are any questions for you.
I feel like,
oh, go ahead, Dora.
I feel like I always have too many questions, but again, that was just another brilliant presentation. Ziad, when you talked about using different measures to kind of flip the script, if you will, with respect to the algorithm, how difficult was it to identify these alternative measures that should be used and that would not exacerbate inequities, as you mentioned?
Yeah,
give us some examples.
Question. Yeah, and I think it comes up with the federal funding too. How do we measure who needs help? And I think that on the one hand, it's difficult because the nice thing about cost is that it's present in lots of data sets that we use. When it's not there, it equals 0. You never have to worry about missing values. So you can, from a data science perspective, you can immediately see why cost is very, very appealing. But on the other hand, in all of those data sets, even claims data sets that we as academics use all the time, there's enormous richness in how we measure health. There are comorbidity scores. We were using electronic health record data that has blood pressure and hemoglobin A1C. So there are a wealth of measures in the exact same data sets that we use to judge patient health that are much, much more reflective of underlying health needs than how many dollars the healthcare system spends on someone. And, we have at the national level, if we're talking about allocating relief funding, there is an amazing program of survey research that goes to people's houses and measures blood pressure in communities where blood pressure is high and people who never make it into the hospital that we drew on when we were writing that paper, and that I think we can do a much better job integrating into measures of need for when we're allocating funding. So, I don't mean to trivialize these things, and I think you raise really important questions, but we have the data. We just need to know that it's an important enterprise, both for racial equity and socioeconomic equity, but also for having policies and programs that do what we want them to do, which is to help people who need help. We need to have those better measures in place.
Great. Thank you so much. I'd like to turn next to Dr. Shreya Kangovi from the Penn Center for Community Health Workers.
Thanks. Just enjoying everyone else's remarks, and I'll try to build on them. Dr. Hughes, I loved that you started with the framing from James Baldwin's quote, "Nothing can be changed until it's faced." So I'm going to piggyback on that. You posited that our inability to face these truths that surround us right now and that are costing lives may be because we don't have the data. But I think it is because we are in denial. And we use the word denial casually as if there's not much we can do about it and it's just, a layman's term. But there is a science of denial. And I think denial among privileged people, including our own selves within academic public health, is a true psychological state that has profound health effects. I have started to talk about health inequity as a psychological disease that affects the privileged but has symptoms in the disadvantaged. We're so used to, as privileged people within academic public health, at looking at the disadvantaged. We study those people, we pathologize them, we intervene on them. But, and often in very well-meaning ways, right? We want to improve people's, A1Cs and blood pressures and, do contact tracing. It's always about them. But until we understand and treat the root cause, i.e. our own perverse psychology, our psychology will manifest in various forms of inequity, including COVID-19 disparities, food insecurity, chronic disease disparities. Those are all manifestations of our psychological disease. And that is, I think, the real knowledge gap. We do not sufficiently understand our own psychology, i.e. the psychology of the privileged, which is comprised of constructs that we all talk about as if they're just part of the water: denial, self-deception, self-enhancement, group narcissism. But these are real things that people know how to do something about. We are just so blind to our own selves that we don't even talk about this as the knowledge gap. Critical race theory addresses many of these. We need to build upon that and basically develop an intervention science to accompany critical race theory. And I don't think that we will be able to do this solely from behind the mirror, i.e. from the ivory tower. Look around this room. Who is speaking right now? We talk about ourselves as all-stars who are going to rise to the occasion and save the day. That sounds like savior thinking to me. And I think what we really actually need to do is stop doing harm. And we need to partner with people who have experienced disadvantage. And this is why in my work, I'm so privileged and fortunate to partner with community health workers, because these are individuals by definition who share life experience with people they serve, who have this disadvantage. And so I think we really need to interrogate academic public health. We need to ask, what is science? Who can do it? And who do we study? And I think we will need the help of people with lived expertise if we are going to build a science that fulfills James Baldwin's exhortation to face our own truth.
Great. Thank you very much. Questions for Dr. Kangovi?
Well, thank you, first of all. That was evocative and provocative. And I'm curious about I've been thinking a lot about the pedestalization of science, as if science is never wrong, that it never needs to self-correct. And I wonder if you can talk about that in the context of what you just described as the group narcissism.
Yeah, I think it's important to define what we mean by science. Is it the essence of science, which I think, again, Dr. Hughes, you called it truth-telling. There, I think, I find less fault with science. But the culture of science and all of its entrapments, its elitism, that's obviously incredibly fraught. And then somewhere in between is just the optics of and the sort of optical illusions of our inability to see our own selves. And maybe there's a fundamental truth to that. And so when science is done by only one type of people, there is an inherent blind spot. And even the best methods, are difficult to overcome that. And really what you need is more participatory science. You need people science.
Great. If I could maybe ask you to apply this to a situation that I think we're very much understanding now, the concern about whether a COVID vaccine will be accepted. There are a lot of assumptions about whether people will take vaccination. There's a lot of, survey data saying people won't. I imagine you might have some ideas on how to think about that question rather than have it be, what's the PR campaign that will convince people to get vaccinated? That I'm thinking is maybe a kind of top-down science with a capital S, way of doing it. How would you think about that challenge from this perspective?
I mean, I think in what you're describing is an example of a general kind of point, which is we often take a target-oriented frame to community-based engagement instead of an empowerment frame. And what, Susan Rifkin, who originally coined these terms, she's a historian of community health programs, describes as, in some public health models, community health workers are seen as a means to the health system's own targets. Oh, let's hire community health workers to get people to take this vaccine. Let's hire community health workers to keep people out of the hospital. That's a target-oriented frame, and that is fundamentally ludicrous, I think, and it is just creating street-level bureaucrats. And an empowerment frame is true partnership with community health workers. You don't say use or get them to or all those kinds of things. And the model is one where a community health worker talks to an individual and says, Josh, what do you think you need in order to improve your life and your health right now? And then does those things. It is a transfer of control and power at fundamental levels. So I'm answering your target-oriented question with a totally different frame. And
I imagine this might be the direction you go, and I wanted to give you that opportunity, but I think it's making the point that it is, the challenge is a lot more challenging than people may think even. There's this whole other layer of whether the question is even the right one to start with, which is, I think, hard for people to always appreciate.
It also would help if China and Russia, and all of us had vaccines that were tested adequately and equitably.
Well, there's a cascade of things that need to happen. There's no question, some of which are pretty, deep into the science of vaccine trials, and others are very deep into that kind of community engagement that you're talking about. Great. Okay, we put a lot of good topics out there for you, Dr. Galea. I will turn it over to you for the final mini talk before we start in with discussion and the questions we've been getting from the audience.
Yeah, thank you, Josh, and thank you, everybody. Batting cleanup, I'm not sure if I'm actually saying something that's novel or summative, but let me capture the thoughts which I was having, but I think they reflect elements of what people have said. I suppose as I see it, there are three buckets of challenges that universities face, because there are actually three distinct, interlocking, but distinct traumas that we're going through as a country and as a world. I could talk about as a world, but I'm going to focus as a country because it's otherwise too big. And I think those are COVID-19, the pandemic itself. I think they are economics, and I think they are the reckoning with centuries of structural racism. And I think these three traumas have all intersected with the core function of the academic enterprise. And I think they call on us to think very carefully about how the academic enterprise deals with all of them. So just a few notes about each of them. First of all, as a meta comment, I think we should resist easy prescriptions and easy solutions at the moment. I think the urgent is never better than the important. And I think the moment is very tempting to prescribe urgent solutions in all caps, which will be shown to be wrong in the long term. So I think as a meta comment, even while diagnosing the problem, I think we have to resist the urge to come up with simple solutions. Simple solutions are never sustainable solutions that bring about real change. So that's at the top level. Now let's talk about COVID for a second. Several of the speakers have talked about the challenge with science speaking truth, bearing witness, and doing so in a way that actually brings data, dispassion, but also a moral compass to what's been happening around the COVID moment. And I don't think that is easy. I think we've had a lot of conflicting voices on that. I think we have been muddled in the science around what it means to actually speak from a place of moral clarity. I think we as a science have shown herd mentality, which does not become us. So I actually do think that the moment calls for a careful reckoning with what is the fundamental role of science in generating scholarship and creative works, and what that means in terms of coming from a place of where our role in society is to be the body that generates those ideas that are useful to move society forward. That's in the sort of COVID space. Economics, apart from science intersecting with economics, actually, and none of the speakers really mentioned this before, so I do want to put it out there. The moment is fundamentally challenging the academic economic model, and that is a not inconsiderable comment. I do think that those of us who have had the enormous privilege of spending a lot of our adult life in the academic world we often exist in a plane that makes us feel like we're actually separate from macroeconomic forces because our livelihoods and our jobs are secure. And that is the moment should have challenged that. It should have woken us all up to that. And I think this really calls for some significant questions about how we structure the academic world and the economics of the academic world, and what role, how much society values the academic world in terms of society's investment in it. And, you know, there's a lot of spin-offs in that in terms of the cost of education, who gets to have education and all that. But I think the bucket of how we intersect with economics at this moment is a really important bucket. Third, which we've talked quite a bit about, is the reckoning with really centuries-long structural racism, which we have known about. I mean, in many respects, at the moment, doesn't tell us anything we didn't know. It has just surfaced issues that we've known, that many people have written about, that now have intersected with the public space, perhaps more visibly than any other time in history. But that, to my mind, asks the academic world to look inward and look outward. I think look inward to see how we structure ourselves. How is it that the academic world, which remains principally a majority group set of institutions, even as there's rapidly changing dynamics in our student body, how do we structure how we think and how we organize ourselves to reflect a world that really recognizes and honestly grapples with deeply seated issues of marginalization of particular groups over centuries. And on the outside world is, how does the academic world bring a voice, a stabilizing, constructive voice to conversations that have been happening in the outside world, often reflecting very urgent, very deeply felt, urgent but short-lived perspectives on the moment, and rather to introduce a longer-term arc to the set of conversations. So to summarize, I actually really think that the academic world has to, at this moment in time, I was delighted, Josh, and grateful to you for organizing this discussion, really try to think about what are we learning and what can we do better in the because of COVID, in the because of the economy, in the because of our growing societal awareness of deep structural racism. And I think all of those are actually super difficult questions. I think they're really difficult questions. I think they're really difficult issues. And I think we have a deep responsibility, deep held responsibility to tackle these and also to resist simple answers, because there are no simple answers. If there were simple answers, we would have elected on them a long time ago. I'll stop there.
Great, thank you. First, let me see if any of the discussants have any questions for you based on that. I have one question for you, Dr. Galea, which is the issue of responding quickly versus responding effectively that you bring up, and the danger of jumping to something that turns out to be wrong. Unquestionably true, but you cross that with the fact that sometimes crises are moments for change that is not otherwise possible. That, you know, if you look in a lot of different parts of history, crises really shake things up. The long-term strategic plan changing things is not as common. How do you balance those tensions?
Yeah, no, I think it's a good question. I think it is important that we ask ourselves who we are. And I think it's important that we ask ourselves, what is our role? What is the role of the academic sector in the world around us? That is, you know, we are ultimately human. We're all human, intersecting with the moment. And when we see an opportunity, that does not obviate the imperative or the temptation to jump in quickly. So I'm not immune to that, and I'm not trying to put that down. But I'm simply saying that when you think about it, whose job is it in society to have the careful thoughts, to instill the careful ideas that can actually bring about sustainable and practicable efforts to create a better world? It really is our job. That there is no other sector in society that is so charged. And I think there's a real responsibility, and I think we should take it seriously. You know, the power that comes with being within academic institutions, with being seen by society as having the space to articulate ideas with impunity. With that power comes enormous responsibility, and I think we need to live up to that responsibility.
Great. Other questions? Great. Well, I want to, Marc, looks like you're going to say something there. No. I want to open up just for a little bit of conversation with this group, if there are any topics. Otherwise, I'll start putting forward some questions we've been getting in the chat. We have a lively audience. Hopefully, you all are tweeting with PopHealthRT hashtag as well. Any general comments? I think there's a little bit of tension between, we have an important role to play now versus we have a lot to fix within academia at the same time. I'll just ask one question if people want to weigh in, like where you strike the balance. This is a slightly different question, I think, than what I just asked Sandro. Do we pause to fix things before moving forward? Do we try to do both at the same time? And how do you balance those, recognizing that there are flaws to the academic model that we've talked about, even as the broader society, may benefit from the positions and advocacy that could be done?
Josh, I want to, and it relates to your question, but also just to kind of piggyback on Sandro's comments. I find myself unable to have a thought without thinking about the election. And it has come up in the context of these remarks, but I wonder if it's worth just spending a minute talking about maybe the one thing that is both important and immediate that academic public health can do, which is to get out the vote. Is that?
Sure. Say more.
It was more of a prompt for others than something that I have an answer to, but I'm just curious about people's, we can sometimes be navel gazers in academia and in public health. And we are in this moment where I think that this is the last exit before New Jersey. Things are going to get strange soon if we don't mobilize in terms of public health. And are we sufficiently in the moment? Are we acting as if we know that?
Well, I know that for voter registration, particularly in getting out the vote, there are academic initiatives like Vote ER to actually sign people up in the ER. You may know more than me about that. There have been a number of public health related discussions around that too. But it's not something that's built in to a lot of practice that happens. And that might, well be an example of something that should change fundamentally for different kinds of community activities. Other comments people have on that?
Just to add to that, in the context of, taking a step back, what does the academic world do? I think we generate ideas and we prepare for the next generation. We translate those ideas. Those are the three things we do. I think what Shreya, if I may, said falls squarely in the bucket of the educating next generation. I actually think it is perfectly within our remit to say that part of our responsibility is to educate about core responsibilities of citizens. And I think a core responsibility of citizenry is indeed to vote. And that's a non-partisan statement. I think that's always the case. And I actually think different academic institutions could intersect with that in different ways, in different creative ways. But I have no difficulty with it. In fact, I think it should be something that we all do, which is to make it clear that civic participation, not just in the world of ideas, but in the very practical world of voting, is something that we should be encouraging.
Mm-hmm.
I was going to add on from a longer term lens. So the urgency of now around voting is certainly not lost on me. And I think one of the things we're exploring is how do we build in measures of civic engagement that are comprehensive, including voter registration and voter turnout, but that go beyond that to look at structural level factors like the number of polling sites available by place and by race, and the ways in which voter suppression or repression might be happening, and to really, again, think about what are the additional measures that we need to start to include as core public health measures that we can demonstrate relate to overall health and differences in health by group as a way of really again, making these structural drivers much more visible and normative in the way that we practice public health.
It's a great example of using public health tools applied to one of the urgent questions that we are facing now. All right, why don't we go to some of the questions that we've gotten, but please, all the panelists here should feel free to jump in at any point. Here is a question about students. How are any of the speakers recruiting, supporting, engaging students, especially students from disadvantaged groups who need to be engaged as part of the population health improvement, given the different challenges for students to learn, logistical, economic, and mental health pressures? You know, I can say at the School of Public Health, we have had to redesign pretty much all of our courses for students. At Johns Hopkins, we have a fellowship program where we give full scholarships to 50 students who are working on the front lines of major health challenges, looking for particularly people who would otherwise not have the ability to get formal training in public health, with a commitment that they would at least keep working with their organization for a year. We have a number of people working in communities all across the country in that program called the Bloomberg Fellowship Program. But I think that this is really unfolding. I know that the burdens of education and classes are falling differently on people in different settings, and particularly an issue for some international students. So I think it's still a moment where at least we're trying to figure out how to most effectively reach students and help students, learn and get out there and be involved in different projects as part of their education.
Let me just jump in from our School of Public Health perspective, Boston University. I mean, so thank you whoever asked that. It is just such a difficult question. It's we're doing a whole range of things, and there's been a substantial discussion about what is the best way to achieve those goals. If one says our goal is to provide the best possible education for as many students as possible, being particularly careful to make sure that we provide extra care for students who have disadvantage of any access. Like if one says that statement, which we say, probably we both agree with that statement, how to actually do that in a moment like this has been like mind-bogglingly difficult. And it has been really challenging. And I think reasonable people can reasonably disagree on different ways to go about it. And because there are so many particularities and so many different circumstances. So, we have redone all our courses. We teach both in person and online. We've been trying very hard to make sure that we lift the undue burden that particular students have just simply because of the challenges they have in their life. But I have no doubt that we are falling short every day, and it is a constant challenge of recalibration. So it's a really it's a difficult moment, and I hope that one thing that can emerge from this moment is that we learn from it for future. Surely, if we don't learn from this moment, we are really not paying enough attention, because there's so many lessons that can emerge from this moment for future.
This is a question that kind of brings in a lot of the different themes we've been talking about. And the question says, how should we think about the prevailing science that our only, or at least major tool to deal with COVID is a policy of isolation and distancing, at least until there's a proven widely administered vaccine? This policy seems inherently inequitable, increasing the exposure and risk to those already most vulnerable. Yet it's pretty much been an article of faith. I might say that if you compare how much there's now understanding of the inequity in COVID, there is much less understanding of how to tackle that inequity in COVID specifically. That there is not a strong voice like, Marc, you've been, talking about here for what can be done to tackle that inequity. And with some of those solutions, I'm sure reflecting the need for the kind of engagement that Shreya is talking about. What can be done? What is academia's role at the moment, where the prevailing wisdom and based on the epidemiology of the virus isn't really getting to some of the underlying reasons for risk, nor suggesting major solutions for those?
And I think there are some solutions that are being bantered about, like guaranteed income and increases in SNAP benefits, things that we have some evidence around, like, or at least we can extrapolate evidence from things like the Earned Income Tax Credit or the Great Smoky Mountain Study. So I do think it's to Marc's point about we know a lot about a lot, and sometimes we might have to extrapolate it in order to get to an equitable solution. But I don't think we don't know anything about the ways that that we could address inequity in the pandemic.
Yeah, and just to add to that, I mean, and some of the suggestions that Sheri just mentioned are, of course, bogged down in essentially gridlock in Congress. So there are some solutions that would, through economic relief, reduce pressure on low-income families to take actions that are risky to their health, which exacerbates the disparity.
Right. Just to push it a little harder, though, I think the question partly is not about so much do such ideas exist, but what can academia do to push them forward?
Yeah, no, that's where I was going. And we don't think about the political sphere in academia very much. We kind of put these ideas out and say that if we model them, they would have XYZ effect on QRS outcomes. But I agree. We don't then say, when we see the partisan piece, we kind of back off. And I think it's not to become partisan. It's to try to frame the messages with greater, impact. And some of that is not just with greater statistical impact, but with greater narrative impact. And I think that's where we're just not good at that.
I had one other thought on this topic, which I think is not at all to detract from these points about supporting income, influencing political narratives, but something that's squarely within the remit of public health and public health adjacent things is expanding access to testing. I think one of the things that was very painful for me to watch was how draconian the lockdowns were and how much better that could have gone had we known exactly who was at risk, who was potentially spreading virus, and could have adopted a much more targeted set of policies rather than blanket policies that affect everyone indiscriminately. And I think that there are a number of testing innovations that were not adopted quickly enough by the public health community that could have been done much better, much more cheaply, had they been built on a more solid foundation of what we were trying to achieve with testing. So I think that the failure in expanding access to testing, certainly the result of decisions made at the federal level, but also the result of decisions made in individual public health labs and hospital labs and everywhere else. So I think that was a collective failure on our part to ensure equitable and widespread access to testing.
Yeah, although we have a lot more testing now and still some of these same problems. Dora?
But I think that all of these issues that Ziad and Marc and Shreya, that people have brought up, is really, we're going to see it play out in terms of the vaccine allocation and what will be the policies to ensure that it's not just those that are the healthcare workers or those that have underlying health conditions or seniors, what have you, are first in line for the vaccine. But then how do we bring in the issues that you started off with, those that are not able to isolate themselves or that live in multi-generation housing? What information do we have that in a systematic fashion that we could incorporate into the decision-making protocols for vaccines when they start to roll out in the months ahead? And so I think these are really important issues, but I also, to your point, don't think we unfortunately don't have the luxury of time, so we can't even resisting the urge for simple solutions, which is absolutely right. But still, at the same time, we do have to think about how we're going to implement these programs on the ground. And so it puts academia, I think, in the crosshairs of really helping to inform thoughtful solutions, but in the time that we have, which unfortunately is not that much time.
Can I just comment?
Sure.
Yeah, I think I don't want to lose from the conversation that one of the challenges that I think academia has faced around these issues in the context of what Professor Hughes just said about time, and is that academia hasn't had, it has not had a trustworthy partner in the public sector. And one of the challenges that I think we have faced is that normally under normal times, the public sector represents the best forum to bring society's collective will together, and it can take what academia offers and weigh it, and then weigh it against various other priorities. That has not been the case because I think I'm saying something that's nonpartisan in saying that the public sector has not functioned anywhere near as effectively as it should have functioned during this time. So as a result, academic perspectives have not been weighed by society, and I think that has resulted in some of these sort of lamentable overcompensations or overreactions one way or another. And so while this session is about sort of academics for academics in some respects, I think it's appropriate for us to point out what we collectively have done wrong. It's almost hard to wrap your brain around where the academic world has fallen short here, because in my assessment, we haven't had public sector actors who have been reliable partners who normally can take the academic input and balance it with other inputs to move societies forward.
That raises an interesting question, which I've gotten frequently, which is if, for example, people have lost faith in what the CDC puts on its website because it's been, manipulated for political reasons, then is there a role for academia to fulfill some of those essentially public functions, and how far does engagement go for academia in times like this, when, as Sandro says, there's obviously a big challenge with the kind of response we've had.
I think there is a role for academia to step in at this kind of time, and then be prepared to step back again when things improve in the public agency sphere. So I think work at all of the institutions around the table. I mean, the Hopkins COVID site is a good example, but many efforts now to even on just simply on the data side and getting a simple story out clearly are appropriate, and we need to step them up. And it is a place where academia can put a strong foot forward, but not to replace its attention. But I think it has to step into the vacuum as it's doing, but be prepared and actually agitate for the circumstances to come about where it can then step back again.
I wonder, in doing that, in that, that urgent situation, are there any thoughts others, might have about what's the critical list of topics? I wonder, Dr. Kangovi, whether you would say there is a role for academia to elevate the voices of people who are experiencing some of these major challenges with COVID right now, and if so, how could that be done?
Yeah, I think in terms of, tables, as many of us nerds do, I mean, along the x-axis, I think about the trajectory of inequity, the social determinants of health stream. It's the root cause is it starts, I think, with the psychology of the privileged. And then it shapes the distribution of wealth and power across society, which influences living conditions, behaviors, and actual health. And I think at each of those checkpoints, there is a set of interventions, if you will, and all of them should include greater participation of people with lived expertise. So at the root cause level, we should have people who have lived experience of disadvantage telling us about ourselves. At the point where we're talking about influencing policy, we should be thinking about policies like guaranteed income, minimum wage, et cetera, that are, again, shaped by people with experience of economic disadvantage at the level of living conditions, et cetera, et cetera, et cetera. And so that's why I'm, again, so passionate about partnering with community health workers. It's not because this is some niche workforce that only operates downstream and does, vaccines or contact tracing. They are a cross-cutting workforce that embodies power sharing. And so I think the answers to your questions can take innumerable forms, but it's the right question to ask.
So to me, that also lifts up the question about academia rules and how people in academia get power, i.e. tenure and promotion and leadership positions. And to the extent that community engaged research and participatory forms of research and forms of research that require deep listening and time, how that butts up against the way that that people progress through academia, and whether or not academia needs to take another look at that if we actually want a different kind of workforce and a different kind of public health.
Yeah, and to even push that, multiple levels further, what does it mean to be a student of public health? And, who can afford to go to public health school, and who can, qualify for that? And how can we really, again, think about and interrogate who gets to do science?
Great. Well, we have a short-term agenda. Tomorrow is National Voter Registration Day, I understand. We have a number of pretty urgent medium term, and we've also talked about different kinds of structural reform within academia. I'm going to give everyone here just a quick chance for any closing comments before we wrap up at 12:30. Maybe Dora, there you go. I felt that over Zoom that you were going to say something, but I was going to ask you because you started so powerfully. I think it would be great to hear from you at the end.
Well, I was anticipating you might go in order again. I'm up next. I think of all the important topics that have been addressed. One of the ones I probably would elevate my last 30 seconds is the discussion on partnership. And I think that one of the key issues is that schools of public health and academia, they can't do it alone. And our success is very much contingent and reflective of the extent to which we partner with communities, with those with lived expertise, as well as those across sectors, the healthcare sectors, the social services sectors, those that are completely outside of the departments of health and similar institutions. I think that is the area that we're seeing move forward in any case in population health, and one that we really should endeavor to accelerate if we're going to be successful and sustainable fashion in the long term.
Great. Anyone else with final thoughts? Well, let me just say, I think this has been such a terrific conversation. We've covered many issues at many levels. We have fantastic questions, which we'll circulate. But I think it illustrates that this is, in some ways, a crisis for academia and public health and population health, too. That we have a moment when the world really is suffering and struggling for reasons that we understand to some extent, and our capacity for responding to that and our ability to do so really matters. So this is a much more tangible conversation than it may sometimes seem. And I really appreciate everybody here joining and everybody for watching. So thank you very much. And I hope people can tune in to the other sessions that are part of this. Whoop, don't know what that is. excuse me. I hope everybody can turn into the, looks like my son is calling me, the other sessions as part of the Population Health Roundtable series about this incredibly important topic. I certainly will be. Thank you all.
Thank you.
Thank you.
Thanks.
Bye-bye.